This is Dr. Magarelli at CNY Fertility, Colorado. Hi. Hello, everybody. Welcome to Tuesday with Dr. Mag, our In Search of the Stork discussions, conversations, questions and answers, all those wonderful things that we do to help us on our journey to create families. Today, I'm going to be talking about the family building properties or processes that we have to allow our LGBT community family members to add to their families. And then, of course, as usual, I will do some questions and answers at the end. I have about 24 slides to talk about. Hello, LaShawn. Nice to see you. Hi. I don't know about you guys, but it's a wonderfully warm day here in Colorado. Beautiful blue skies. Gosh, just amazing. The trees are all green. Everything is great. Marlena, hi. You did my retrieval today. Good. I appreciate that. Hey, Jennifer. That's one of my lovely medical assistants. Going to be a nurse here pretty soon. You just keep at it. Hi, Ashley. Hey, Natalie. Good to see you. And Pretty Girl. Nice to see you. Such a pretty name, Pretty Girl. I am on Instagram, but honestly, all of the slides will be here on Facebook Live or on YouTube Live. So tell your friends. Hey, Tana. Nice to see you. Welcome aboard, Ashley. Nice to see you. And today we'll start with a nice one day, Dr. Meg. Well, a nice discussion on how we can, especially it's Pride Month, and I thought it really would be nice to just bring things together around our LGBTQ community and begin asking some basic questions about fertility, because it turns out we're all the same here. And so what I'll do today is I will broaden the discussion. It was informative to me that there are many changes in our community in terms of definitions, and it's a challenge, to identify appropriately, to be respectful. And so that's, that's a challenge. So I want to sort of bring us all to the same definition of things. So Kelsey, I'm confused when I can transfer my frozen. I lost my son at 21 weeks. I'm so sorry. And I've been told 8 weeks from the nurse practitioner, then told 4 to 6. Well, it's okay. There's no magic number. 8 weeks gives your body the chance to heal. 4 to 6 weeks is not that different than 8 weeks. It's just, don't get tied up in those kinds of details. The real issue is, are you well? Have you rebuilt yourself? That took a metabolic toll on you. And we want you well, healthy, and prepared to create, to make your family bigger. I mean, that's kind of what we're doing. So with no further ado, I'm going to begin the discussion today. The topic is family building in the LGBT community. All righty, so let's move on out. Okay, so we're going to go, this is sort of an outline of what we're going to talk about today. After I'm done here, I will have a discussion, questions and answers. But what is the LGBTQ? What is that? What does it mean? The key principle that I want you to remember is it's more an issue of resource and logistics, not biology. People are people, but when you're in a female-female relationship, a male-male relationship, transgender relationship, the resource, sperm, eggs, uterus, those are the key things. And then how to get them logistically together to allow things to work is really the goal here. My Instagram doesn't seem to be working, so I apologize. But anyway, and then we're going to do what's good for the goose may not be good for the gander, and absolute advantages and relative advantages of the LGBT community clients and outcomes. These are biology based, not sexual orientation based. And then, of course, we will have a Q&A. Thank you, Rebecca. Okay. So one of the things that we have to get more familiar with, and I'm going to kind of blow this up for you guys so you can see it a little bit better, is this idea of who you are has many components to it. And specifically when it comes to sexual identity, there are now very nice diagrams like this one, which will help us understand terminology. Now, most of us understand anatomic sex, right? We are born with a certain chromosomes, and those chromosomes determine whether or not we have a phenotype, we look like males, look like female. Well, then and those are chromosomal and anatomic. The self is also your gender identity. This is your internal sense of being a male or female or along a spectrum. So, here we have a spectrum between man and woman, and identifying yourself may be any way along this spectrum. From the chromosome standpoint, you're either truly male, truly female, or there's this thing called intersex where you have a combination of male and female chromosomes that can cause different phenotypes. Then you have how you orient yourself in life. This is the gender is a person is attracted to. In other words, am I attracted to women? Am I attracted to men? Or am I sort of in the middle here, where I have no attraction either way? I'm attraction to everybody, or I'm bisexual, which means both. And then finally, how one manifests oneself through social norms. In other words, how you present yourself to your society. Whether you present yourself in a feminine character or a masculine character, or really that central character which says neither male nor female, I'm just presenting myself as me. All right. So it's a continuum which goes from our biology, sex, gender identity, gender role and expression, sexual orientation, sexual behavior, and sexual identity. And the terminologies, as I mentioned before, are pretty straightforward. Like for biologic sex, you're either male or female, or what we call intersex, both. In gender identity, you can identify yourself as male or female or transgender, female going to male, male going to female. The expression of your role, your gender role, what I do, how I present, clothes, hair, cosmetics, masculine, androgynous, or feminine. My orientation, romantically, emotionally, sexually, is it straight or heterosexual, homosexual, lesbian, gay, or pansexual, bisexual? Sexual behavior with whom I choose to be sexual. In other words, I choose, this is orientated, but you could choose to be sexual as a heterosexual, homosexual, or pansexual. And then how I view myself. Am I viewing myself as straight, lesbian, gay, or pansexual? Now, again, I'm only defining these really for our full audience here so that we all understand this transition we're seeing in our society. So a lot of times this identification as a she, her, he, him, they, them, he, him, they, them, she, her, these are beginning to be fairly fluid. And honestly, sometimes it gets confusing. Now, there's a lot of weirdness, and not only in our society, but in issues related to fertility. Well, for one thing, health insurance companies think fertility is optional, like plastic surgery for aesthetics. Well, that's not, fertility is a inalienable as well as biologically driven pursuit of life. It is not an option to appeal to someone. It's an option. It's not even an option. It's a requirement to identify ourselves, in terms of our personhood. Okay. I mean, and so the health insurance companies, are still challenging them, saying, "Hey, man, fertility is important." But here's the weird thing: fertility coverages basically was geared for heterosexuals that couldn't get pregnant naturally. Well, what about gay or lesbian couples? I mean, they're not able to procreate naturally in terms of they don't have all the parts. And so even now, there's challenges to this idea of who gets covered for fertility. Here's the other side of the story. The LGBTQ community tends to think they have unique biology issues for reproduction, and that's not true. And I'll show you that today. It's basically sperm, egg, uterus. What combination we use to make that happen doesn't is simply a logistical issue, but essentially for everyone, it's sperm, eggs, and a uterus. Lesbians, this is something we see a lot with lesbians. They believe that the only issue to getting pregnant is access to sperm. That is not 100% true. And a lesbian woman could have as many reproductive problems as a heterosexual woman, but she just have not been revealed because she hasn't had access to sperm. Some folks think their own eggs are better than donor eggs, and I'll show you that that's not necessarily true in terms of reproductive outcomes, or they think their own uterus is better than a gestational carrier. Again, not necessarily true. And if you're male, you can't be a father, and again, that's not true. So these kind of thoughts that people have around the LGBTQ community are really just misunderstandings or basically ignorance, in not a pejorative sense, but they're basically ignorance. So let's get this going here. Okay. So what do you need to make a baby? Well, you need access to sperm. Well, how can you do it? You could have access to your own sperm, your partner's sperm. It could be a friend's sperm. It could be a sperm bank. It could be a family member. You need access to eggs. So it could be yourself, a partner, a donor egg from a friend, an egg bank, a family member, surrogate, which is rare, which is where they provide both the uterus and the egg. And then what about access to a uterus? Well, it could be yourself, it could be your partner, a gestational carrier of someone you know, or it could be a gestational carrier agency. And finally, it could be a surrogate also, which typically in California is what they originally provided. So those are the very, very, very many options that we have for our folks in the LGBT community in terms of, okay, how do we access the source of the gamete or the uterus, the incubator, and how do we manipulate these things so that everyone is basically served? So here are some biology points that I need to make over and over again because it goes for men, women, doesn't matter. Men go through puberty and begin producing or creating brand new sperm at about 1,000 per heartbeat. So about 1,000 sperm are created per heartbeat. Whereas women go through puberty, and it's an interesting change, and I'm going to show it to you. They actually slow down their egg loss. Since birth, women are losing 10,000 eggs per month during infancy and childhood to up to 1,000 eggs a month during puberty and through 35. And then after age 35, they go up to the 10,000 eggs per month that they did before until approximately age 44 to 48, they run out of viable eggs. These are biologic facts that apply to everyone. The uterus really does not age. It works at least until age 76. That's the world record so far. And then this last point is close relatives, if married, think sibling marriages, not legal, are linked to poor reproductive outcomes. So the more unrelated you are, the sperm and egg are, the better. Hence why donor sperm works so well, donor eggs work so well, donor embryo works so well. And again, I'm reinforcing, you don't have to have all the parts in your relationship to make a really viable and healthy offspring. So here's just some more little facts. The testicles are constantly producing new sperm. It's called spermatogenesis, and it takes about 2 to 3 months for that sperm to go through the whole process of being born and getting out. As I said, about several million sperm per day are made, about 1,500 per second. And you could, by the end of a full sperm production cycle, which is 64 days, a man can make over 8 billion sperm. This may seem like overkill, but they release anywhere from 20 to 300 million sperm cells in a single milliliter of semen. And most times men will ejaculate between 2 and 3 milliliters of sperm. So what about females? The follicle number, which is a representation of those follicles that could have eggs in them, show a very different picture. Unlike men, women do not make eggs during their lifetime. Their eggs are made before they're born, up to 7 million. By the time they're born, they lose at least 4 million eggs before birth, which comes out to 200 to 300,000 per month. Now, from birth to puberty, the young girl will lose about 10,000 eggs. So going from that 2 or 3 million down to 300,000, where around here it's about 300,000, where they reach puberty. And then during puberty and ahead, they lose about 1,000 eggs a month until that magic age of 35, where you see this abrupt decline in eggs, and that's where we see this 10,000 eggs a month loss. So this applies to gay men, gay lesbian women. It just, this is our biology, and we have to manage it. So the unique questions that need to be asked when we're dealing with the LGBTQ community, and you should ask yourselves these questions, from a lesbian couple standpoint, whose eggs are going to be used, and that's considered the prime. Whose uterus, that's secondary. Is it going to be a reciprocal IVF where the sperm and the egg are, where the egg and the uterus are basically swapped? One partner provides the egg, the other person provides the uterus, or is it going to be all on one person? Or in that lesbian couple, is all of it going to be handled with one part of that couple, and then everyone and the other partner is going to be support only? These are questions you should be prepared to answer, because we're going to ask you those questions just so that we know, where you guys are at as a couple. Now, for gay couples, whose sperm is going to be used? Is it going to be one or both sperm to make embryos? In other words, are they going to be all one sibling, or are they going to be essentially stepbrothers? And then is one partner going to be pure support? Just there to be pure support? Just unique questions that need to be answered. So for lesbian couples, what options do we have? Well, intrauterine insemination or intracervical insemination. These are those home kits you can get where you can spray the sperm on the cervix, little cup, or they have a little cup, you put the sperm in. A lot of times couples will buy this sperm and then do this at home for a while, and if it doesn't work, then they'll come to a doc. If you go to a doctor, it's called artificial insemination. Usually a little more complicated, and for home kits, you just need the kit, and then essentially you need to know when you're ovulating, so ovulation predicting kits. For insemination, we take over. We have ultrasound monitoring, fertility medications, time trigger shots for predicting the optimal time for insemination. And because we actually will wash the sperm, you're allowed to put that sperm inside the uterus without any side effect. You cannot put unwashed sperm inside the uterus, or the woman's uterus will cramp down like she's going through labor, and it's extraordinarily painful. Now, again, when a heterosexual couple has access to sperm, usually it's 2 or 3 times per week, which allows them to have multiple episodes of sperm access. Whereas with lesbian couples, right now, semen sperm samples can run anywhere between $700 to many thousands of dollars per sample per try. So what I tell my lesbian couples is, man, you don't want to spend that kind of money at home. It's much better. Come to CNY, and our costs for IU are extraordinarily cost competitive. But by using that $1,000 sperm sample, we can optimize it with medications, with timing, with a trigger shot, etc. And as you can see here, unlike what most people think, the best you can expect in the 20 to 30-year-old is about a 12% chance that an IUI will be successful. Only about an 8 or 9% that an IUI will be successful for 31 to 35. And you can see that even every 2 years, you're seeing this quite remarkable decline, such that at 40, the chance for an IUI to work is less than 3%. So again, typically over 35, these folks should move to IVF, because it's really just about 10% chance for success. So IUI versus IVF, well, look at the graph here. as I just demonstrated, you can see that the best a human can expect in your 20s is about, that's a little high, actually. It's about 12%, down to 2 or 3% in your 40s. But look at IVF. It starts right now in the 20s and they're 50%. And this is basic IVF. With IVF with genetic testing, it's actually in that 60 to 70%. So beginning to choose your options, that you want to do is going to be critical. So for lesbian couples, they can use IVF with their own eggs and their own uterus. IVF with their own eggs and an embryo transfer to the partner's uterus, that's reciprocal. IVF with the partner's eggs in your own uterus, and IVF with the partner's eggs in a partner's uterus, but also gestational carriers, surrogates, those, but for the lesbian couple, in all cases, you're using donor sperm. Now that can be from a relative, or it can be from an anonymous donor source or a friend. Now, gay men, pretty straightforward. We need a source for the donor egg, and we need a gestational carrier. So here are some special considerations. If you're dealing with patients who are going through transition from male to female, simplest thing to do is have the couple save sperm, or have the individual save sperm. We've been freezing sperm for over 100 years. If the transition is female to male, a little more complex, but absolutely, we can save eggs and freeze eggs, and or you can make embryos with an anonymous sperm donor and save embryos. They tend to have a much higher chance of pregnancy per embryo if you do it, if you know they're embryos prior to freezing. Another special consideration is the conversion where the female became a male but wants her eggs now. So in the past, she wasn't thinking about her eggs, she didn't save them, but now she wants it. Well, now we have to start adjusting hormones. It's likely she has eggs. The testosterone is not going to stop her from having eggs, and it's not going to accelerate the egg loss, but we have to change that hormonal milieu to allow those follicles again to be stimulated. And then the male to female, but now wants to use what is his original sperm. And again, it's an issue of hormones. We have to re-regulate, sort of turn back all the changes so that now we have to get sperm production. Now, this may be a little bit more difficult. You can get arrest of the basal cells. That's why it's always, always, always better to save eggs and save sperm prior to any of this. Now, I said there are some advantages that people don't talk about in the LGBT community when it comes to reproduction. Well, first, for lesbian couples, there's 2 sources of eggs. And so what I always recommend is that both partners get all of their eggs evaluated, their uterus evaluated, and decide how to optimize. There's 2 sources for gestation, meaning you have 2 uteri typically. And then you can do reciprocal for family building. So you can create a couple in which you have one child being the egg source is one partner, the next child, the egg source is another partner, one child born from one mother, one child born from another mother. I would imagine there's got to be books about that, the depth of that family building. It's not here, but I mean, it's not been done that I've read, but it's just a very interesting psychological question to ask. In terms of the gay men, they always use the ideal egg and uterus. So they're always using donor egg. So the egg is the vast majority of the reason for success is the quality of the egg. So by using donor egg, you automatically are in a situation of optimizing. And a gestational carrier is usually has a proven fertility. So again, you're dealing with someone with proven fertility. Now, the other advantage of it is that as transgender folks, they can usually revert, if it's a hormonal transition. So that's not true in most of medicine. Once you make a decision, like a tubal ligation, et cetera, it's very hard to reverse. But here, there's a biochemical way to recreate the fertility option. Now, the big issue that has been historic, but I think is less so today, is the identity, the ownership, we'll call it, or the parental, the parent, the parent who is labeled on the birth certificate. So there is a legal consideration, and I would only go to lawyers who are in the field of reproductive medicine, uh, so that you understand and the doctors understand and the staff understand, and you're all together, excuse me, understanding that the laws regarding who's on the birth certificate. And even though you may have interviewed a really nice doctor and interviewed a nurse team, you need to interview and understand who's going to be doing coverage, so that who's allowed in the birth rooms and those kinds of questions, like I said, are getting less and less, but they used to be big issues in the past. Be sure that the legal issue of parenthood are clear and established prior to delivery, especially if a gestational carrier surrogates are being used. In some states, surrogacy is illegal. That's a surrogate, by the way, provides both the egg and the uterus. Egg donor, sperm donor relationship involvement should be clearly outlined. A lot of people say, oh, I'm going to use my best friend sperm, but you remember in some states, he's identified as the father. Even though you were friends, even good marriages end up in divorce. Some friendships can break apart, and you could be in a legal quandary if that's not established prior to the birth of the child. In many states, the mother is simply the person that birthed the baby, regardless of the genetic connection to the baby. So it is something for you to consider when you're dealing, when you're planning. And we have good lawyers to talk to, good books to read, and and seeing why we do this all the time. So it's something we can help you with. Well, anyway, again, this was sort of a short overview, as promised, about the issues related to the LGBT community. I think we all benefit from knowing this, but I'll open up for questions. If anyone has a question on the topic or on anything now, because I usually tend to open it wide open to questions. I know we have a few people. Okay. Rebecca, thank you so much for telling my team is amazing. There's no question. I'm proud of them all. I'm proud of the global travel team, the financial team, the donor team, the docs. They're just wonderful people to work with. Okay, Angelica, would you recommend transferring an euploid embryo with low mosaic for someone who just turned 40, or is it better to do one at a time? Yes, don't do them combined. Do one at a time, because the mosaic has a higher chance for miscarriage, which could take the euploid with it. What about the percentage rates for mini IVF versus traditional IVF with straight couples who have conceived repeatedly but suffered the loss of an ectopic pregnancy? Our clinic is saying traditional, even with our success, would still be better. Is that truly the case? You said you're how old, Kayla? So remember, okay, mini IVF. We go over this every single week, and because it's so confusing, and I'm sorry, someone invented the term mini. It means less. We give less medicine, therefore less response. It's that simple. And for some folks, it saves them money. That's why we do it. It doesn't have any magic properties. So if you want fewer eggs, fewer embryos, fewer normal embryos, then use less medicine. If you want more eggs, more embryos, and you can make more eggs and more embryos, and if you're less than 35 with normal ovarian reserve, you absolutely can with more medicine, then go traditional, because it's all about finding the eggs that are normal out of a bunch of eggs, finding those embryos that are made that are normal out of a bunch of embryos, and finding which of those embryos are chromosomally normal out of a bunch of embryos that are made, and which one will stick. So it's all about numbers. Really, that's what it's about. I hope I answered your question, Kayla. And percentage rates at less than 30, it's about 30% chance of achieving a pregnancy for either one of those. It doesn't, it's just what you have left over as well as what you have to choose from, because really one egg, one embryo, one baby, you never know which egg is going to make it. So you might as well feed as many, in my philosophy, as many as you can. Christina, with reciprocal IVF, is one embryo used or can more than one be implanted at one time? Well, it depends on the age of the female whose egg made the embryo. So if she's less than 30, we strongly recommend one embryo if it's untested. If she's 30 to 35, it's one or two. 35 to about 40, maybe two embryos if untested. And then over 40, we can do up to 3. Any tips for making shots less painful? Linz. Well, some people actually, there's a patch you can get, ask your nurses, it numbs the skin, but remember, it's an oil. It's an oil. Oh, Christina, 39, yeah, I mean, 2 untested embryos would be reasonable for a reciprocal. But yeah, progesterone and oil, it literally, it's in oil, so it actually, the pain is forcing oil into a muscle, and the muscle doesn't want to have oil put into it. Believe me, it does not want to do that. Some people use a heating pad on medium. Okay. Elizabeth, here, sharing our eggs with another lesbian couple, and we go to Albany in the morning for retrieval, and the other couple will be in Denver. Wish you all. Oh my God, Elizabeth, that's fantastic. That is so fantastic. And sharing, that's so important. You know, creating family. I guess my point about donor egg working more effectively, donor uterus working more effectively was to say, the biology of reproduction is such that the less similar folks are, the greater the outcome. It's just the nature of humans and genetics, and so that's very nice, Elizabeth. Wow. Oh, wow. God, that's amazing. Any other questions? I know this is a somewhat of a unique topic, and it has been asked by certainly our educational team to spread more words out there. Angelica, second transfer coming up. You did my first one. Can I request you to do my next one? It would be my pleasure, my absolute pleasure, Angelica. Do you know what day you're going to be here? Because I want to make sure I'm here. Janet Gallegos, completed my workup and completed the semen. All the results are in the portal. What next? You call. Basically, Janet, you keep calling. We get 8,000 phone calls a day, or use your portal, actually. Use your portal message. Portal the nurse team and say, hey, I want my treatment consult. Now, the doctor may have already put a treatment plan in there for you, so then you might just say, listen, please read my doctor's plan and tell me what my next steps are. We're good to go. Now, Janet, where are you going to be getting your retrieval? Elizabeth, what do you suggest, as we will only have half the eggs, day 3, or try to grow them to day 5? We had 20 follicles on Monday. Elizabeth, did you say how old you were? Give me the age, female, okay? Okay. Who's providing the eggs? That's what I need to give you an idea of whether you go day 3, day 5. I like to grow to day 5 because it just says so much more about the embryos. And by the way, again, cleavage stage transfer or blastocyst transfer. Okay, 34, but AMH is great. No, 34 is great. It's 34 and AMH is great, not but. So day 5. My office, good. Since I wasn't able to reach anybody, but I'll try again tomorrow. Okay, yeah, please do that. Yeah, just get a hold of us, Janet, and call or stick on the line and say, listen, I talked with Dr. Magarelli last night, and I'm ready to go. I want to set up an appointment, okay? Let me write your name down here, and I will Tell them to reach out to you, but you do it too, okay? Because you know me, I got a lot on my mind here. Any recommendations on a bank for a financial loan? My health insurance does not cover that. Gosh, I don't. Yeah, well, actually, yes. CNY Fertility does self-funding. So we do lots of funding for our folks. So if Erica, if you're going to be doing work with CNY Fertility, we our financial plan. We don't have just talk to the financial folks. We definitely provide loans to folks. Michael, what's the oldest patient you have had a successful IVF with their own eggs? 43. I would say 43. I've had people pregnant up to 48, but they tend to miscarry, unfortunately. But I think 43 live births, maybe a 44. I think most people in the United States would say 43 or 44. I mean, that's what I would expect. They also do medication donation. Please give your leftover medications for those in need. Well, that's fantastic. Absolutely. But remember, we as doctors can't recommend that kind of stuff because it's a FDA. You can't give somebody else your medicine, but whatever you guys decide to help each other is up to you. All righty. Other questions? All right, Michael, how old are you, Michael? If you want to say, or do you, is for somebody else? Baseline FET is Thursday. I'll know more then. However, I would let the global team know that I would love for you to do my second transfer. Absolutely. CNY has it at least in New York. Elizabeth Ferguson, CNY has it at least in New York. Well, they're very generous, you know. Yeah, wow. Okay, you can, no. Okay, I see what you're saying. You can donate unopened medicine. That's what you can do. Yes, you can donate on. Some people sell it in the black market, and they, you know, that's. But yes, you can donate it, and then you can gift it, and then we gift it to someone else. Absolutely, we do that here in Colorado. I think we do that at all of our centers. Again, with the goal of everybody helping everybody. That's our goal. So I don't know what these website addresses are. Is that Isabel? You trying to tell us something there, or is that you, or is that a group? What is that? Does a hysteroscopy need to be done again if it didn't work? Oh, if you did an embryo transfer, and if your hysteroscopy was done within the last 6 months, I wouldn't jump to doing another hysteroscopy. I would do an ERA, an endometrial receptivity assay. I would maybe do HCG washes or even PRP washes. Definitely do acupuncture. If you haven't been diagnosed or tested or treated for endometriosis, I would do that too. Tasha, I'm excited. I'll be up there in like 2 weeks. Okay. Well, make sure you say hello up there. Okay. So yeah, hysteroscopy is just the gold standard by which we check to see if somebody's uterus is normal. What are the requirements to use a GC? You do it in Colorado? Yes, Stella. Gestational carriers, they're not a requirement on your part. They have a requirement, to be healthy, non-smoking, that sort of thing. So if you don't have a uterus or your uterus doesn't seem to be working, then you just basically sign up to get to either through an agency, through us, for a gestational carrier, and that person, and then you go through the legal, and they will help you get that all set up. My gynecologist was helping me get my pretest, wondered why I needed hysteroscopy. I recently had a pelvic ultrasound, because those are not the same. A pelvic ultrasound looks at the meat of the muscle. A hysteroscopy looks at the cavity of the uterus. Not the same. And hysteroscopy, again, is the gold standard. Do you recommend an HCG wash and intralipids prior to your first transfer? Only after failed. We recommend it initially, because why fail? Tasha, I will be coming to do my fresh transfer. Good. Sophia, I'll be there in about 2 weeks too. Okay, we'll have a party. Okay, Michael. Okay, good to know. Yeah, it is different than a pelvic ultrasound. A lot of people equate those, and some of the pelvic ultrasounds are very good, but they're not perfect. And if you're investing thousands of dollars in a procedure and you have a polyp that goes unnoticed with the pelvic ultrasound, then that's kind of not good. I mean, it's a lot of money wasted. And we're very sensitive to that. You know, we want to make sure you're using your funds appropriately. All right. Sorry. Another question is if we had an HSG test done, but it's been a little longer than a year, do you have to repeat the test? Hallie, your goal is to ensure that your embryo sticks. Typically, we use 1 year as our limit between testing. Just update it yearly. Now, you say no, then we say no. If you miscarry, you miscarry. It's not something we try to prevent those kind of things. Sherry, I got a laparoscopy and hysteroscopy done last September and nothing changed. So yeah, it's not even been a year. So yeah, don't do anything. Hello, Amadeus Black Diamond. Good to see you. Saludos desde Arvin, California. Saludos. All right. I don't know where Arvin, California is, though. So what else is new? We're still expanding, hiring nurses, hiring doctors. We're now opening up for sure, and it's done in Sarasota, Florida, folks. It's coming fast. So that's kind of cool. Stella, I'm sorry, Sherry, I have a narrow cervix and tilted uterus. Does that make me infertile? No. Stella, what is the difference between Menopur and low-dose HCG? Well, in Menopur, it's made by a manufacturing company called Ferring, and it contains FSH and LH, and low-dose HCG acts just like the LH part of Menopur. So it's a cheaper alternative to Menopur because Menopur tends to be very expensive. Elizabeth, GC, my sister is one. They should have had a live birth and care for a child. Okay, the birth should have been healthy. And yeah, these are great things, Elizabeth. If they have a family member, then some clinics are more lax with certain factors. Also, you can go independently, but you should always have a lawyer. Yes. You should have given this talk, Elizabeth. Okay, Tasha, could I bring my 4-year-old daughter to take a picture with you since you did my child? Of course you can. Just tell my front desk and I'll either meet you downstairs or we'll find a way. Elizabeth, would love to see more peer support specialists in the infertility field. Yeah, I don't know how to do that. Can the Colorado location do hysteroscopy during retrieval? Yes. A few weeks ago, there was a live where you mentioned that they may be monitoring we can do at home. Oh gosh, Holly, I wish that we are so busy with patients to do this test to see home monitoring. I would love to jump on that bandwagon, but honestly, you know, I've gone from 30 cycles a month to 130 cycles a month of retrievals and from 30 transfers to 130. So it's amazing. And as I was saying, we're opening up a center in Sarasota and other places. I think 3 centers are opening up this year. It's hard to do these experimental things, but I'd love to do that. Olivia, what would you recommend my first step be? I'm 41, so time is running out for me. My friend has offered to be a surrogate for me. My fiance and I are not, I lost that, ready. Oh, no, make embryos, Olivia. You don't need GC. Make as many embryos as, oh, thanks, Hallie. I just came back from Steamboat. I don't know, this doesn't show how tan I am, but yeah, I really got a good tan while I was in Steamboat. It was, had a great time, fantastic time. But no, Olivia, you don't need to, absolutely don't need to do a surrogacy or GC or any of that yet. What you need, because your uterus is good until age 65. So save, thanks, Michael. Save embryos, make them, save them. Does AMH need testing on a specific cycle day? No, it's really cool. Yes, so you can do it anytime, but usually we do it during the first, second, or third day, but it doesn't have to. Megan, when do you do acupuncture before retrieval and after retrieval? Yes, and yes. You do 9 treatments before the eggs come out, and you do 8 treatments approximately before the embryos go back in. It's called the Credenda Magarelli Acupuncture Protocol, CMAP. You can find great information at www.eastwindsacupuncture.com, www.eastwindsacupuncture.com, Dr. Credenda, or you can go to the ABORM website, www.aborm.org. I think Florida, we're trying for January, pretty much. Fariha, I am 39, but regular periods, but doctor said I have PCOS. Is it normal? No, PCOS is a description. It just describes characteristics of a menstrual cycle, characteristics of hormones that can, not always, interfere with fertility. So it's just hereditary. It's part of your family. It's part like your height, your eye color, you have PCOS. It's just a part of you. So normal, abnormal, it's hard to say when 40% of women have PCOS now. Hard to say. You mentioned Florida as the new locations. Hallie, the reason I only mentioned Florida was I'm not 100% sure what state. I think Philadelphia. Philadelphia, but I don't want to say something I don't know. I know for sure it's Sarasota, Florida. And I know for sure that Colorado is expanding. We opened up the whole floor, so lots of stuff to do. Stella, I'm not sure it's for all treatments, but we're training left and right, the team. We got the facility. We got to build out the laboratory. I'm betting, and again, Dr. Kiltz will know better than I, that we'll probably be doing all treatments down there come January if we keep moving as fast as we are, and that's really fast to have something up and running there. It's going to be fantastic. I'm very excited. It's a good location. Dr. Kiltz is certainly familiar with Florida very well, and actually, Dr. Fink, the doc I just hired, is from Florida, knows the area very well. I think we've hired 2 new docs already for Florida, so they're really lucky. We're hoping to find another reproductive endocrinologist here so we can even expand what we're doing here. But even so, we're just rocking it. Okay, other questions. If you do not have a period naturally, do we have to induce a period before starting the process? It depends on your lining, Hallie. If your lining is thin, the answer is no, and you don't have any cysts. If your lining is very thick, you kind of want to do that. Megan, stim day 5, having lots of discharge, is that normal? Oh, absolutely, Megan. That's not only normal, that's fantastic. The term I use is you're getting juicy. Basically, all of that wonderful medicine is growing follicles, producing estrogen, and that estrogen is causing that beautiful mucus. No, juicy is good. Juicy is good. Bo. TSH, is that a problem during stim? Yeah, you want to get your TSH in at least below 2.5 or 2.0. Start a low dose of levothyroxine or NP thyroid. So, Michael, if we have all the other tests checked off the list, the hysteroscopy can be done by CMY during retrieval. Absolutely. Jasmine, have you had experience with retroverted uterus with IVF? Almost every day. Almost every day, Jasmine. We have retroflex, anteflex, retroverted, anteverted, midline. When you're doing as many as 500 to 800 patients a month, you tend to see a lot of stuff. And that's just me. All righty. Yay! Megan, when doing retrieval, do you ever find bowel is in the way of getting to the ovaries? In the way is a relative term. You got to know what you're doing. You can use pressure. You can use assistance. I usually have an assistant or 2 in the room if we need to move the bowels through the belly. You can go through the uterus if the bowel is in the way. So the answer is yes and yes. Do you always have to cancel cycles if there are cysts? No, it's an option because we want the best for you. But if time is critical, meaning you're running out of eggs critically, then you may decide, you know what, I'd rather get some eggs than no eggs. And so if you don't do a cycle, you're not going to get any eggs. And if you do one with a cyst, you may get a slightly fewer. But the bottom line is you're going to get eggs. So one egg, one embryo, one baby, right? That's the whole kind of goal. So yes, it depends on the cysts too and their location if they're in the way. You may want to consider waiting, but a lot of people don't like to wait, Stella. So yeah, you don't necessarily have to remove the cysts before. Slow day. I think it's a slow Tuesday. Usually, okay. You're welcome. You're welcome. Okay. What else can we talk about? Things are status quo. We're getting busier and busier. Okay, Blake, I have unexplained infertility. Got pregnant in 2018, miscarried at 4 weeks. Went through IUI in March, failed. You didn't tell me how old you were. Then first IVF cycle, got pregnant, miscarried at the same time. Yeah, Blake. Definitely you want to look at antiphospholipid antibody workup, a thyroid workup, PCOS workup. You want to look at acupuncture. You want to look at the keto approach, low carb. You want to look at the chromosomes on your partner and you, if it's a heterosexual relationship. You want to make sure a hysteroscopy is done to make sure there's no polyps or fibroids. Michael, a saline test can be done as well. Yes. Now, if the E2 is less than 2,000, can I trigger only with Pregno? Yes, of course. Do I have to use Farika Malik? Do I have to use meds? I'm not following that. Blake, 23. Oh, yeah. Okay. Yeah, you want to get a workup for sure, Blake. See what's going on. What's your favorite thing about Colorado? I used to vacation in Estes Park. Well, to me, it's a combination of weather, people, clean environment, open sky, nice people, great places to eat, sports outside, lots of sunshine. Tasha. So I was supposed to be taking Omnitrope, but had a reaction and had to stop. But I've been taking Serovital. Do you think we'll have a good results too? Absolutely. I was just going to say use Serovital. Michael, yay, we are already coming your way. Great. Christina, my consult is scheduled for July and my August cycle will start about 4 weeks after my consult. Is it realistic to expect to start in August or would it be September? September, possibly October. We're getting about 8,000 phone calls a day, 80,000 requests for care a month. I don't know what state you're going to, but the more information you have at that first visit, absolutely, I tell folks, be ready to commit to what it is you want that first visit, because that's your ideal visit where the doctor can come up with a complete comprehensive plan for you guys on that first visit, just in case we don't want you to get lost in the shuffle. So for sure, have a clear plan. I want to do this. But now again, be open to options. But if you're just going to see us in July, you may get ready in September. Christina, a lesbian couple wanted to do reciprocal IVF. Egg donor is 39 and carrier is 36. What would be fit in the percentage chart that you showed earlier? The egg donor is the one who predicts the outcome. The uterus does not. So the egg donor predicts the outcome. So if the egg donor is 39, that's where your predictions come in. Okay? Or egg provider, not donor. Blake, my husband and I have 10 frozen embryos. Would we be allowed to transfer 2 embryos in our next transfer in July, Blake? Well, I don't remember. Oh, you're 23? No, we don't. You're 23. You have 10 of them. Your chance for quadruplets is pretty darn high. And believe me, I know it sounds fun, but having quadruplets. I've never seen a person who's had twins ask for another set of twins. So persons with quadruplets, it's a whole different world. Um, and I don't know if this is your first or second transfer, but at 23, there's no advantage to putting more than one in, except for quadruplets, quintuplets, octuplets. There's really no, and that's not an advantage. I was being a little bit facetious there. So you really want to put in one at a time. That's what the uterus wants. And at your age, they're very potent embryos. Now, were you the same couple with the miscarriages? I don't remember. And you don't want to put a lot of embryos in if you're miscarriage. What is best to get more embryos? Back-to-back cycles or dual stim? Absolutely, Stella, back-to-back cycles are better than dual stim. Back-to-back cycles just means, folks, that you do one cycle, you have your retrieval, wait 2 weeks, start another cycle. Duo stim means you have one cycle and then you immediately give the drugs for another cycle. So in a month, you have 2 cycles. That's good if you have cancer and you don't have time, but for numbers, it is absolutely not advantageous. You know, Blake, I'm really worried that you got to have a clear reason for these miscarriages, and putting more embryos in is only going to increase your miscarriage rate. It does not reduce your miscarriage rate. It may not even increase your pregnancy rate, but it may increase your twins, triplets, quadruplets, septuplets, etc. So I think maybe getting a little bit more information as to why you're miscarrying is probably the most important thing. And then the other thing, I don't know. I don't think these are tested embryos. So if you don't know if they're tested, it could be a genetic. Hi, Lyric. Good to see you. I'm glad you're here learning. That's a nice picture. Lyric is my one of my newest nurses. Delightful, great energy, always willing to learn. Just got a fabulous team. Lyric and Veronica and I've got Stacy and I've got Andrea, I've got Amy, I've got so many wonderful Adrian, Melissa, Caitlin, Tammy, Dora, Randy. Anyway, is there any chance of something showing up on an HSG and clearing up on its own? Yes, that can happen. I've had 2 hysteroscopies since 2020, and I have another HSG coming up next cycle, hoping it's nothing this time. Yeah, I mean, it doesn't sound like that's a big issue for you, Jillian. Is your uterus? That doesn't sound like it. If you haven't had polyps, some people who make polyps tend to make more polyps. But if you haven't, yeah, I think you should be fine. Okay. All righty. Any other questions? I don't know. There's a lot of people texting me. So, okay, Kelly, so confused on how the process works for IVF fresh and FET and what's more convenient if traveling from Pennsylvania to Syracuse. Time needed off work. So confused. There's nothing confusing. IVF process is to get more eggs. Fresh transfers are fine. Frozen transfers are good if you have PCOS or ovarian hyperstimulation or you're doing genetic testing. There's no magic between a fresh or a frozen. Going to what's more convenient if traveling from Pennsylvania to Syracuse would be a fresh transfer, so you don't have to come back. We can just get the retrieval, do the transfer, get the retrieval, do the transfer. That's the most convenient from a time off work. Andy, info on HCG boosters. What reasons would someone need them? Nobody needs them, Andy. They're just simply supplements, like any supplements, that may contribute to improving your reproductive outcome. That's all it's about. What can we at CNY do to improve your chances of achieving a pregnancy on the first try? All of the lists, go to the Family Building Guide, www.cnyfertility.com/resource, Family Building Guide. Go to Amazon. Dr. Kiltz has the Family Building Guide there if you want it. It's all about what are the ways we can add things that may improve your outcome so that you're successful. We've already cut the fees as low as I think anywhere in the United States, because we know that most folks need more than one try to make a baby. So that's what we can do. These other therapies are things that you can do or add on to what you're doing in order for you to improve your outcome. What determines how many embryos are transferred? The age of the female, and the guidelines from the American Society for Reproductive Medicine. All righty. How do you know if a woman has endometriosis? Well, okay. All righty. I think what I'm going to do is gonna, because now everybody's waking up, but unfortunately I've got to go. So this was really fun, very interesting to do this topic on the LGBTQ community and how we can help, and how normal it is for us to help. Next week will be questions and answers, as I always do every other lecture. All of these lectures, by the way, are recorded, so you can go back, review, ask questions. The portal absolutely is your best way of communicating. Secondly, do expect at least 6 weeks, after you've met with the doctor on your first visit, before you're doing anything other than testing. This idea that you go in the next cycle, that doesn't work anywhere in the United States, believe me. And if it does work, they're not doing very many cycles. And as I've said, we get 8,000 phone calls a day and 80,000 requests for care, and I think we're doing now probably 1,000, probably 800 cycles in all of our centers per month. Probably that's right. Maybe 700 cycles. So we're working as hard as we can. So you're very welcome, Michael. Thank you for your wonderful questions. Thanks, everybody. Make sure you go to Facebook Live, like us, as people say, and I wish you the best. And please, always, when you come to see me in Colorado, say, hey, I want to see Dr. Magarelli, and say hi to him because I've been on his lives. That really makes my day. So anyway, you guys have a great evening. Thanks again for joining me. Just be fertile. Thanks. Bye-bye.